Today's presenter is our VP of Product Content, and her name is Jennifer Bishop. And Jen, hand it over to you.
All right. Thank you very much, Dusty. Feels like a long time since I've done one of these, so this is exciting. Dusty mentioned there, and I just wanted to reiterate, because probably my biggest question is, why didn't you handle all the CPT codes? And the answer is, it's just too much to do in one webinar. So this webinar is going to focus on those things that are typically done from the Chargemaster, the 7,000 to 9,000 series in a nutshell. Tomorrow's is going to be more HIM focused, or the surgical procedure codes 1000 to 699. And then Thursday is going to be more from a physician perspective on things. So that'll include the E&M changes and, a summary of the important RVU changes that facilities don't care so much about. All right, we're current as of today, but especially this year, things seem to be changing pretty quick. So stay tuned for to VitalWare and other sources for updates to all of this. All right, probably the second biggest question I get is, why don't your totals match the totals that I see from the CPT book or from the AMA? And it's really important to understand that we are discussing changes that are effective January 1st, 2021. The AMA is publishing all changes that occur between the publishment of the 2020 book and the 2021 book. So that'll include everything that they do in July. This year, it's not just July, it's all throughout the year they've been making changes. They consider those all new. We are looking at only 2021 changes. So don't expect them, my numbers, to match what you may see from the AMA or other sources. All right, so we're going to start with the radiology section here, the 7,000 section. And we have a few things going on here. So not nearly as many as in previous years, which is good, but there are some important changes. So we have a new code for lung cancer screening. It is the CT of the thorax without contrast. Basically, this is a direct replacement for the HCPCS code of G0297. So CMS created a code to describe this service a few years ago, and now the AMA has decided that it's worthy of a permanent CPT code. So that's what this is. These guidelines down here for the following criteria of who would be appropriately screened with this procedure would be a patient between the ages of 55 and 80 who's got a fairly significant smoking history. They're also either currently smoking or recently quit, fairly recently. Smoking cessation counseling should be done if the patient is still currently smoking. And this is kind of an important one, right? They need to be entered into a lung cancer screening registry in some way. We also have a new code to evaluate radiation exposure. It is the medical physics dose evaluation, and notice that it includes the report, but it's not typically a professional service. Usually this is something that's done by a hospital-employed medical physicist, and it would be done following either a diagnostic or a therapeutic procedure. Just some little guidelines there. If there's a dose above 5 gray, it could be significant. Over 10 gray is considered by the Joint Commission to be a sentinel event and has to be reported. So there's a new code to actually capture that work from the facility perspective. We also have a couple of deleted codes. They deleted 76970, and I thought it was interesting that they saw that that code was billed like 27,000 times in 2018, but when they went back and reviewed, they couldn't find any appropriate indication for 76970. So their assumption is that it may be being inappropriately reported as a follow-up ultrasound study after a procedure. And they wanted to remind, they being the AMA, want to remind everybody that follow-up exams like that are already included in the procedure. So that one is just going away. 78135 is kind of the same thing. It didn't have nearly the usage, but they just couldn't find that it was clinically appropriate to be billing that code at this point in time. So that's been deleted. I put both codes up as suggested replacements, but probably it would be more appropriately the unlisted unless you've just kind of sort of picked the wrong code for the red cell survival study. All right, moving on, we have 3 codes that were revised. You can see over here that the only revision to those was to add the word diagnostic to these studies. And that's simply so that we can so that we can differentiate them from the screening one that they added for the low dose CT screening of the thorax. So no big deal there. They just want to make it clear that these are the diagnostic. That new code is for the screening. We also revised a couple more codes here. 74425 has been revised to remove the specific exams from the long description. So it's basically just going to now allow you to use 74425 for any antegrade urography service. Doesn't have to be one of those specific ones. And 76513 was just basically just clarified a little bit by adding unilateral or bilateral. The AMA felt that people were getting confused as to whether that would be a unilateral or a bilateral procedure. So they're just clarifying that it's both. We also have some new guidelines that have been added to the radiology section. And basically these were added as a result of some new category 3 codes that have been added that we'll talk about in a little bit. But they're really just clarifying for you so that you can get to the right section of codes and what's included. So they wanted to make clear that the CT and the CTA services in this section include the images, the reformatted images, and the cine review. If you do contrast enhanced services, and I've given you the code range there, those include the quantitative assessment, and it tells you what that includes. And that's basically, like I said, just because we have some new category 3 codes that represent add-on services that are performed using CT data. So basically, they're just telling you if you're doing a basic assessment of the CTA, that's included here. If you're doing some add-on services, we need to go to the category 3. And they also wanted to make clear that only one of these exams should be reported per encounter. And that's it for radiology, much easier than what it has been in years past. So we're up on the laboratory and pathology, and there are always tons of changes to this section, but they're kind of the same changes. So we'll go through this section pretty quick. So even though there's a lot of them, they kind of all group together. So we have 10 new codes for therapeutic drug assay. So that's, monitoring of a particular drug. We've added these particular drugs, so these would no longer be reported with an unspecified code. We also have some new guidelines around the definitive drug testing, and it's basically just trying to help you out here by letting you know if it's not in the definitive drug testing section that you can use an unlisted procedure, but if that particular drug that you are testing is in the therapeutic drug assay or the chemistry section, you can go there as well. All right, they also, again, wanted to do some clarification. These drug tests, there's a lot of different tests and they're performed in different ways, and which code you select is dependent on all of that. So to clarify a little bit, they are putting in some definitions to let you know that the therapeutic drug assays should be performed to monitor levels of a known or prescribed, can be over-the-counter medication. There is a listing of definitive drug classes that is found in your CPT book. Trying to look, if you've got the professional edition, it's around page 592 to 594. That isn't comprehensive. So they're directing you, if you don't see your drug class in there, go to the FDA drug classification if that's possible. And if you're looking for a metabolite, that's going to categorize to the parent code drug. And again, they give you some directions for if your drug or metabolite isn't listed. Again, you can go to the therapeutic drug assay section or the chemistry section. So there's a lot of steps to get the right code in the laboratory section. Who knew drug testing could be so complicated? Apparently the AMA and the way they made the codes. All right, so we have a bunch of codes that are added to the molecular pathology section. So I think in the next slide, maybe a couple down, I've got exactly what the tier 2 and the tier 1 procedures are, what that code range is. But basically we have 16 new codes because these tests are being broken out of the less specific tier 2 procedures. So I'm not going to pretend to understand what these things are, but I definitely wanted to make sure you had a list of the new ones. So we have a lot of them. So feel free to read through those. You will get a copy of the presentation for sure. All right, the tier 2 molecular pathology procedures got a couple of new guidelines. Again, just some clarification here that you want to use the molecular pathology procedure that includes your specific analyte. Let me hop back here one. You know, this being the analyte, the TP53 or the UTAF. If you don't see a code that has a specific analyte in the tier 1 or the tier 2, then you can go to 81479. All right, so as a result of those 16 new codes being moved from tier 2 to tier 1, we had to update the descriptions for the tier 2 because those tests, those specific tests move out. So if you look at this, there's 16 different changes to these 1, 2, 3, 4, 5 codes as a result of moving things out. All right, MAAA changes are the multi-analyte algorithmic analysis. I think I got that right. So just as a reminder, these are codes that usually provide a score or a probability for a given disease based upon the molecular pathology reports and the patient demographics information. So these tests take two sets of data, bring them together, and basically tell you how likely it is that one of these conditions is present for the patient. So we've added a new one for a genomic sequence analysis panel for epilepsy. We have some bacterial vaginosis and vaginitis tests that have been added. The melanoma, the cutaneous melanoma, thyroid cancer, and idiopathic pulmonary fibrosis. And remember also, all these MAAA codes are specific to a particular test being done. So they are unique to a lab and a particular test. All right, we deleted one, 81545. Basically, that test is no longer performed. As I mentioned, these are proprietary specific tests, and the lab is no longer doing that one. So there isn't any kind of direct replacement. On to the chemistry section. Fun, fun, fun. We've added a couple of new codes. There's one code for alcohol testing, any specimen but urine or breath. And notice that it's an immunoassay or enzymatic method. So if you're doing definitive drug testing, you want to go to the 80320. And if you're doing another specimen, that is going to go another direction, if you're doing the urine or the breath. 82681, we just added a code for the free estradiol. We already had a total estradiol. If you did free, you had to use an unspecified code, so that's been added. We're also revising a few codes in this section. If you'll notice, it's really just because of the changes I mentioned one slide ago. We're adding the fact that this has to be total estradiol, not free. Basically, just this is becoming a parent code of the new code. So we're just adding the fact that this is now a parent code. And the estradiol is getting the word total added to it so that we can clearly differentiate between the free and the total code. On to PLAs. Please don't ask me to read all of these. I'm not going to go there. The PLAs are, again, just as a reminder, they were designed to be able to add codes quickly and on the fly. The PLA codes are released every quarter. They are not evaluated for clinical efficacy or anything like that. Basically, if a lab sends out a test to a request for a new code to the AMA and says, we're doing this test and we don't have a code for it, that's pretty much the end of what the AMA does to validate the whole thing. So again, these are proprietary. They are specific to a certain lab and a certain test, and that's why these tests seem to come so fast and furious. So we only have 13 for 2021. But there are many, many more than that if you look over the course of the year. So this is one of my numbers that's not even going to be close if you look at the AMA's number of added codes. And again, I will let you guys read through all these. Specific lab information about who performs these tests is also available in VitalWare, in Vital Knowledge with these codes, and also in Appendix O of this CPT book. All right. That's enough of that. The lab stuff is lots of changes, like I said. All right, let's move on to the medicine section of things here. All right, we have one code added for immune globulin, which is for rabies immune globulin, 90377. Nice and easy. The optomology section has a code that was added, specifically the 92229. This is a child code of 92227 and 92228. So that is for remote imaging of the retina. Notice that this code is for automated analysis and report. So this is a test that can be done basically by almost anybody, and it provides results over to the physician for use, but it's all kind of automated. Right now, this technology has been approved for diabetic retinopathy patients, but we are expecting other retinal conditions to probably be added in the future for this procedure. All right, they hacked apart 92227 and 92228 in order to get it to kind of mesh and fit a little bit better with that 92229 that we just saw on the previous slide. So notice that we've got, right now, it's still imaging of the retina. Instead of just saying for detection of disease, it now includes monitoring of the disease. And they just made it, I don't know about clearer, but they changed their terminology. Instead of saying remote imaging, it now says remote clinical staff review. That's really all they did with this, is make sure that you knew it didn't have to be a physician. This one is clinical staff. And this one is actually for the physician's part of things. Other than that, it looks like a lot of change, but it's really not too much change. So I just added some notes down there. 92227 is for use when clinical staff reviews the report. 92228 is for use when the physician reviews the results. And again, 92229 is automated. We also added some codes for the VEMP testing or the VEMP testing. And these are, I say new tests, they're new codes. They're not necessarily new tests, but these allow for testing of the otolithic organs, specifically the utricle and the saccule of the inner ear. And just to note that these do complement information that has already been obtained, maybe from caloric testing or some other kind of testing. So it's not the same thing. The 3 new codes we have are 92517 through 92519. So that first one is for cervical, and that would evaluate the saccule and the inferior branch of the vestibular nerve. The 92518 is for the ocular vent testing, and that evaluates the utricle and the superior vestibular nerve. And then 92519 would just be both of them, because they can both be done at back to back, essentially. So if you're doing both, don't report 92517, 92518. Use the combination code there. All right, we also have an added code for the in the otorhinolaryngology section for the auditory evoked potentials. So these are the involuntary recordings that are done when the patient is either asleep or very relaxed. It's usually used for babies for the newborn screening, or for other patients who aren't able to indicate an auditory response for whatever reason. Basically what we did is we took 2 codes. I'm going to hop ahead here real quick and then hop back. So we took these 2 deleted codes that were really non-specific. They just said comprehensive and limited, and we broke them out. So those 2 fairly non-specific codes are being replaced with 4 codes to delineate between the clinical indications. So we have screening for 92650. We have hearing status determination, 92651, threshold estimation at 92652, and the neurodiagnostic testing at the 92653. All right. And these are the AMA's recommendations for replacement. So the more complicated or comprehensive testing, you're going to pick one of these, the threshold or the neurodiagnostic. And the limited testing would be for the screening or just the hearing status determination. Okay, moving right along, we added a bunch of codes to the cardiovascular section. If you look at it, basically what we're doing is breaking out. Before we had codes that were just more than 48 hours, and they've decided to separate that out a bit more. So we have 4 new codes that will be for use if the testing goes for more than 48 hours up to 7 days. And you can see these are broken out just as the other ones were. So this is the complete test with the recording, the analysis, and the interpretation. And then they're broken out like most of these are. So 4.2 would just be for the recording. 4.3 would just be for the analysis, and 4.4 would just be for the interpretation. And because we did that, we have 4 more codes right along the same lines: complete report, recording, analysis, and interpretation. These are for use, though, for testing that's done more than 7 days up to 15 days. So let's go summarize that a little bit here on this screen. So hopefully this helps a little bit, and these are guidelines that have been put into the book. So if you're doing a Holter monitor up to 48 hours, you want to look at the 224 to 227 range. Excuse me. If you're doing mobile cardiac telemetry monitors, so the patient is wearing a monitor, and that monitor transmits data to an attended surveillance center, and that's really important. The surveillance center has to be attended, meaning there has to be somebody there to look at and receive that data 24/7. Those services are 93228, 229. If you have an event monitor that records when it's triggered, so usually the patient will trigger it and say, oh, I feel a little funny right now, let me trigger the recording. Or it can be triggered remotely if, for whatever reason, the physician wants to record the heart rate between 5 a.m. and 7 a.m. It can be triggered that way as well. This one also requires transmission to an attended surveillance center, but it's only on request. It's not constantly transferring the data, but it still does have to be an attended surveillance center 24/7. So even though they're not always getting the data, they have to be available to get it whenever. 4.1 to 4.8 are the long-term continuous recorders. They record all the time, and these codes don't require the attended surveillance center. So those are usually reviewed by the physician, maybe when the patient comes in to their appointment, although they can be transferred to a surveillance center as well. All right, pulmonary section isn't too bad, but we do have a new code, exercise test for bronchospasm. Notice that it includes the pre and post spirometry and the pulse oximetry, and it is without ECG recording. So because of that, we had to revise the description for the existing one. So essentially what they're doing is giving you an option for if no ECG recordings are done. So the existing code 94617 will now require that ECG recordings are performed, which in fact it always did. Now we've got the code for if you don't do the ECG recordings. Okay. Not too bad. We also have, this is where I expect most of the problems to be. We have deleted 5 codes that actually, in my experience, are fairly often used. However, according to the AMA, don't shoot the messenger, but according to the AMA, these codes, there's no clinical reason to have been performing these codes. They're usually part of another service, and therefore the AMA felt that these were probably being used incorrectly, and so they've just deleted them without direct replacements. So I've listed out for you some codes that would typically include the expired gas collection. Doesn't mean that this is none of these are a direct replacement for this, but again, per the AMA, this shouldn't be being done in a vacuum anyway. The pulmonary compliance study has been deleted. The CO2 determination by infrared analyzer has been done, and the bronchial challenge testing with antigens or gases have all been deleted. And that's it for the medicine section. We are moving along here. Luckily, we didn't have nearly as many changes for this year. So let's talk about some of the category 3 codes. Remember, one of the first changes that we talked about in the radiology section was some additional guidelines for the CTA data, and this is why. We have these new codes for automated quantification and characterization of coronary plaque using the CTA data. So this is a proprietary algorithm process that takes data obtained during the CTA, and it can basically spit back out a report to the physician to let them know exactly how severe the patient's coronary artery disease is. This is amazing to me, but it's been proven to be darn near as effective as actually going in with a catheter on the patient. So, and not invasive at all. So that's really a neat thing that we can do that now. As I said, these findings are provided to the physician. He has to review them and report on them, but basically all the work is kind of done up front, and then it's just up to the physician to decide how to proceed. It's only reported once per CTA, and you do not include the 76376 or 76377, which are those add-on codes for the 3D imaging. We don't want to add those because this already includes 3D imaging. So here are those codes, kind of broken down again along the same way that most of these codes are. So you'll notice that this one is the complete. It's the data prep transmission, the analysis, the review, and the interpretation and report. 0624T would just be for preparation and transmission of the data. 0625T would be for the analysis of the data, and the 0626T would be for the review and the interpretation. We have some new guidelines that they just put in, again, to clarify this whole thing. So, and a lot of these you'll see are kind of a repeat of the guidelines that they added to the CTA section in the 7000 section. So one-time use, we're not going to report it with the 763, 76, or 77. And if you're doing non-invasive estimated coronary fractional flow reserve, you want to go to the 0501 to 0504T. And so now you kind of see why they put that language in with the 7000 CTAs as to what is included in a standard evaluation of a CT, so that you know when to use the these other categories. All right, we also have some new codes for cone beam CT of the breast or breasts. And this is just, again, an enhanced technique. It provides way better spatial and contrast resolution. It's really great for patients with dense breast tissue that the mammogram isn't always helpful for. It can be performed with IV contrast, but doesn't have to be. I think it frequently is, but doesn't have to be. And it also includes 3D imaging, so we also don't want to report that 763, 76, or 77 with these. Here are all of the codes. So you see that we just have it broken out into without contrast, with and without contrast. And then we have a set of codes for unilateral and the exact same set of codes for the bilateral. So 6 new codes to basically describe one service, but it makes it easy, right? We don't have to worry about modifiers or any of that kind of stuff. So. All right, another new category 3 code, and this is a technology that's available from a company called Hypermed. This is actually, some of this new technology stuff, you can see the geek in me come out. It's just really interesting. The fact that they can use visible light spectrum and go over the surface of your skin and actually see where the tissue has adequate oxygenation or not so adequate oxygenation. And then, that tells them exactly where they need to focus if they're looking at doing maybe a procedure to restore flow. It's really cool. So it's all color coded. It uses visible light waves, spectral light, and it's intended to be used in patients with diabetic foot ulcers or peripheral vascular disease, just so you can target in and see which sections actually need attention there. We have another new code, 0639T, which is for a wireless skin sensor for assessment of cerebral spinal fluid shunts. So for patients that need a shunt to drain out the CSF fluid, either from their ventricle or from their spinal canal, this is a constant source of problem for these people, because it's not uncommon for these shunts to actually become obstructed or partially obstructed. And previously, the only way to actually diagnose that was to open the patient back up and see. This is going to make it possible to not have to open the patients back up. So it's going to capture flow data, and it transmits that data to the physician so that he can just see whether or not the shunt is working as it's intended to work without having to open up the patient. All right, we have several deleted codes from the category 3, and as a quick reminder here, just to everybody, The Category 3 codes represent new and emerging technology. So they're really designed to all be temporary codes. They're just to allow the AMA to do some tracking, see how these things are being used, and then decide whether or not they need a permanent CPT code. You know, they get to be promoted up to Category 1, or they a lot of times can just be deleted because it's found that that service isn't going to be done so much, or it can be described by an existing code or any other number of reasons. So this year we have a lot of them that didn't meet the cut to get promoted up to a Category 1 code, and so they are just being deleted. They are the cryopreservation of the reproductive tissue, and that's just going to go to an unlisted reproductive medicine procedure. Breath test for heart transplant rejection, that would go to an unlisted chemistry. And the long chain omega-3 fatty acids in the RBC membranes would also go to an unlisted chemistry procedure. But the whole thought behind these is these procedures really aren't done very much, so you may not need those codes. We also have a common carotid intima media thickness study. And that, I think, has been just superseded by some of the other procedures we were talking about, not done very often. So that would just go to an unlisted as well. All right. Way back now, it feels, in the medicine section slides, we discussed the new codes that are being added for the different groupings. There's one 48 hours up to 7 days. And there's one more than 7 days up to 15 days. So because of that, we are actually deleting these that kind of covered that whole section. So these come in 4s, you know, the scanning analysis, the recording and storage, both, and the review and interpretation. Yeah, we have lots of deleteds in the Category 3 this year. All right, the external heart rate and 3-axis accelerometer data, holy cow, up to 14 days is being deleted. And notice, because I would not have put these here. This was a little bit of a surprise to me. Notice that they're going to the neurological section, unlisted procedures, because this is for purposes of diagnosing nocturnal epilepsy seizure events. So even though we're monitoring heart rate data, it's actually to diagnose seizures. So that is why they're going to the unlisted neurological, if in fact you do those procedures. We just have more of those codes here. Same deal. It's for the purposes of diagnosing nocturnal epilepsy, and we are moving on that one. All right, we're also deleting the multispectral digital skin lesion analysis, okay, for the melanomas and the atypia. I can't explain why we deleted these without a replacement, except they just must not have gotten the use. So they're not used, they tend to just disappear. And they're also deleting the oversight of the care of the liver assist system. And this was more of a physician code, but that would just go to an unlisted E&M code. And finally, last but not least, we have some guidelines that were added to the Category 3 section just to prevent some confusion with all of the new ICD services. So basically, they wanted to clarify for everybody these substernal cardioverter defibrillators and what you're looking for in order to assign these. So these are a generator with one substernal, so under the breastbone rib cage electrode. The generator goes in a pocket that usually lies over the rib cage, and the electrode is then tunneled under the skin into the anterior mediastinum. It doesn't go into the pericardial cavity. It goes outside of it and close to it. And it's not for chronic pacing. It's usually to provide an electric shock to patients whose heart goes into a very unstable rhythm. That's the primary function of these. And so they wanted to clarify that as well. And that does it for our changes for the CDM focus for this year.
Awesome. Thanks, Jen. I am glad you're the one pronouncing a lot of those words and not me.
Not always well, but
way better than I would be doing. I want to remind the group, we always get questions about the CEU's presentation, all that stuff. So yes, we do make it available to you following the presentation. So we'll send you a link where you can see the presentation, watch the recording, as well as information on how to get the CEUs for today, since you did attend live. So that should go to your email. If you don't get it, wait a day though, but if you don't get it, you can email marketing@vitaware.com. We'll make sure we get that to you at that point. Otherwise, we have some great questions, and if you have questions now, please put those in the Q&A panel, and we'll see how many we can get answered now live. Coupled with this, is G0297 being deleted?
Yes, I believe that it is. We just got, finally, everything is so delayed this year, but we just finally got the HCPCS codes. We didn't get a full file, but yes, I believe the AMA, CMS is deleting that G code as a result of the new AMA code.
All right, perfect. How about for lab codes? When do we use the PLA versus tier 1 or tier 2?
This question comes up all the time to the AMA, and the answer is if you have a specific PLA code, which again, they're going to say this is the test by Mayo Clinic, and it's this. If you are doing that specific test, you want to first look to the PLA and the MAAA codes, because those are specific to a test, a vendor, a lab. If you don't have that, then your next stop should be the tier 1 codes, because those are for particular analytes and assays. That's analytes, it's not the right word. But those are particular to a specific item being tested. If you don't have that, then we're going to go to the tier 2, which are specific, but also generic. So within those 8 tier 2 codes, they have listed out for you the things that you would be testing for. So if you don't have it in there, once we've made our tier 2 stop, that's when you want to go to the unlisted, the 81479. And that happens because these are being added so fast and so furious, this pathology testing.
I should probably ask you this one first so you can answer, Jen, but is the presentation, is it up to date with all the files rules released last week?
Yes, it is, except I normally try and throw the HCPCS codes into this, and I just didn't have those in time. But yes, most of what I saw in the final rule is around those HCPCS codes, and we don't necessarily have all of that in this presentation, but we will certainly be updating you through Vital Alerts and the product itself.
Yep, someone did ask if we were planning a webinar on the HCPCS changes specifically, but yeah, once we gather the information, we'll make sure it's published within the product. If you aren't a customer, we'll make that available to you as well on our article resource section, so you can still get those updates and make sure we're supporting the industry. Mm-hmm. Okay, next question. Can 0631T be used like a TCOM prior to hyperbaric oxygen?
Okay, wait a minute. Give me 1 second to be looking this up. Okay, so that is the transcutaneous measurement of the oxygenation. And the last part of that question was about hyperbaric oxygen?
Yeah, prior to hyperbaric oxygen.
They didn't publish or say anything about restrictions to it like that. And that's a fairly new procedure. So I really don't think that is included in the hyperbaric oxygen at this point. They may at some point add that, but yes, there's no restriction on that at this point, that it would have to be done prior to, before, during, after. So that should be just fine.
One person is asking, I thought E&M level 1 CPTs were being deleted this year, but evidently not, since you did not include in the presentation.
Well, remember I said the E&M changes relate to physicians. And so that's going to be in our Thursday webinar. I have had a lot of questions about this, like, well, wait a minute, we still assign 99201 through 99215 for our non-Medicare payers. But I want to remind everybody that even if you do that, you don't assign your facility E&M levels based on the CPT code descriptions. You can't. You have to assign those levels based on internal guidance, policies and procedures written by your specific facility. And therefore, the E&M changes that are changing the descriptions and how the physician determines medical decision making and those kinds of things, those aren't going to impact the facility at all in any way. Other than, yes, 99201 is being deleted. And the reason for that is the AMA couldn't come up with a clinically valid reason to bill a new patient a level 1. If they're a new patient, they're pretty much always going to have to be more than a level 1. And that's the reason for that change. So just a reminder, if I understand I didn't put it in here, that was on purpose because it is not impacting the facilities at all. And we need to make that clear. So thank you for bringing that up.
Yeah, just a reminder to everybody, I put in the chat panel, I put a link to our webinars page, and that's where all of our webinars we host, and you can bookmark that if you want. But we have 4 more webinars this month still, so we're just getting started, and we hope to isolate some of that information and go over it in more detail. With that said, and Jen, I'm not going to hold you to this, and people listening, don't hold Jen to this, but do we have any ETA on when the HCPCS will be available on the dashboard for the VitalWare users?
Oh yeah, I'm expecting that to be done today. They're being loaded right now. Like I said, it was a little tricky this year because they haven't released the full file. So we had to do a lot more manual manipulation of things than we were used to, but those are in the process of being loaded right now. So I would definitely expect them end of day today.
Perfect, that's great. If a facility is not performing the interpretation and report, would they be able to report the new code of 92653?
Let's just buzz back up there, shall we? Sorry if I'm making anyone dizzy here. There we go. You know what? I saw that question asked from my advisor, I want to say last week, and we were actually writing into CMS to try and get that clarified because that is a little odd right there. They all say with interpretation and report, except for the screening. But yet they are payable under the OPPS. Typically, the facility doesn't do the report. So I think our best advice right now would be, what we're thinking is it would be reported with a 52 modifier, but we are looking for more information on that particular question.
So we will do an FAQ doc. So all these questions being asked, but we're not going to get to all of them. We still have a few more, and so we'll probably only get to 2 more, and we'll be out of time. But we will make sure we'll answer all of them and get those posted where the webinar will be as well. With that said, 2 more here. How does the new drug testing codes affect G0480 through 483?
Good question. They really don't. Holy cow. The G0480 through 83 are for the, now I'm trying to find my other book. They're not for the definitive drug testing, or these codes that were added for the assays, I think is what's being asked. They're not for the assays, they're for the broad drug testing, which really hasn't been impacted here. The new codes are for assays or monitoring of levels. The G0480 to G0483 are for testing whether or not that drug is present. So different procedure altogether.
Okay, and unfortunately, it's going to have to be our last question, but again, we'll post all the answers to that page. Otherwise, feel free to, if you use VitaWare, get in the product, and we typically answer a lot of those questions there as well using MyAdvisor or other functionality. All right, last question. Would that statement about E&Ms also apply to G2211 and G2212? Are those chargeable, reportable on the HV side? I don't know what that statement is, I guess, necessarily. Does that make sense to you, Jen?
It does make sense to me.
Okay.
What I'm looking up right now, so sorry, are those particular codes. G2211?
Yep, and then 2212.
Yeah, it doesn't look to me like that's reportable. Those look like the, of course, I don't have that right now, those particular codes without jumping out of what I've got right now. I'm going to have to get back to you and answer that one later because those are new codes for this year. So,
Okay.
Kind of a down one there. But I don't want to give anybody wrong answers. So.
Yeah, no, it's better that way. So again, we have a bunch of questions. We'll make sure we get them all posted. Last reminder, the slides, the recording right now that you're on, and your CEUs will all be emailed to you and a link of where to find those. But honestly, that webinar page I put in the comments, if you bookmark that, that's where we end up posting everything, past ones even. You can view most of our webinars on demand there and download the slides and things like that. We have live chat on our site, so if you have specific questions about how to get your CEU, if you didn't get it or anything like that, that's a great place to start as well. Otherwise, yeah, hopefully we're just getting started with you this week, and you talk to us on Wednesday and Thursday as well. Thanks, Jen. Great content. Right. And thanks everybody for joining us.
Thank you. Bye.